Hello everyone. I will talk to you about an interesting topic. Endovascular thrombectomy with or without intravenous Ateplase in acute stroke. If you like, you can follow me on my social networks on Facebook, Twitter, and YouTube. Okay, we start. Endovascular thrombectomy. Definition is the removal of thrombus blockout under a mesh with stays, and thrombectomy is most commonly performed of an arterial embolism, which is an arterial blockade often caused by arterial fibrillation and a heart rhythm disorder.
Patients get deep vein thrombosis, which is blood clots in the deep veins of the leg, and that can cause problems with obstructing the blood flow so the leg swells up. It can also cause a problem where the clots can break off and go into the lungs and cause what's called pulmonary embolism. But we can treat both these conditions with some aggressive catheter techniques. And the way we treat the clots in the deep veins in the legs is what we'll do is we put the patient on their abdomen, so they're prone, and then we put a little tiny needle into the popliteal vein behind the knee, and then we can thread catheters or little tubes up the leg and into the clot. And then what we do is we give some clot busting drugs as well as some little catheters that can blend the clot and dissolve it, and then ultimately you can clear the clot, and so the leg swelling goes down, and you can also minimize the likelihood of the clots going to the lungs. Sometimes people can't be on a blood thinner to treat the clots in the legs, and so we'll put in a little device called a filter. A filter, it looks like an umbrella, but it doesn't have the material on it, and it goes inside the inferior vena cava, which is the main vein draining the abdomen, so it also drains both legs. And that can be threaded in either from the femoral vein or from the jugular vein. It's done under local anesthesia, and it's threaded in under x-ray guidance. It usually takes about 10 minutes for the IVC filter to be put in. Now, sometimes people don't need the IVC filters for a long period of time, and we try to remove these because they can cause problems if they're in too long. And so what you can do is, usually from a jugular vein approach, you can thread a special little catheter in to where the filter is, and then you can capture the filter and pull it inside a catheter and pull it outside the body so that the filter is no longer inside the vein.
Application in the nursing care. Care should focus on the continued serial neurological assessment and monitoring of the physiological parameters and neurovascular assessment so that potential complication can be caught early. The last critical baseline produced assessment parameter is blood pressure. Blood pressure is usually elevated in the setting of an acute stroke as the body tries to maintain adequate cerebral perfusion.
Last follow-up. Baseline characteristics were well balanced in two groups. Only 8% of patients in thrombectomy alone group and 5.8% in the combination therapy group had intracranial atherosclerosis-related large vessel occlusion, which is lower than those reported in previous study for Chinese population. Workflow time were comparable to those in Western countries.
Pros and cons. Pros: increase early perfection, increase final perfection, started produce time, improving microcirculation, required violent thrombectomy. Cons: increasing hemorrhage reach, daily thrombectomy, thrombus migration, anaphylactic reactions, increasing cost.
By intravenous Ateplase has become the standard of care for patients with acute ischemic stroke due to large vessel occlusion in the anterior circulation since 2015 after the publication of 5 landmark trials. Risk and benefit of Ateplase before thrombectomy are controversial. Treatment with Ateplase may increase the likelihood of reperfusion, but it may increase hemorrhage risk, delay thrombectomy, increase risk of thrombus migration, reactions, and increase costs. Therefore, randomized evaluation is required. We designed this directed.
The efficacy of the endovascular thrombectomy treatment with Ateplase was demonstrated in the patient in our population from the Quito Metropolitan Hospital who were in the therapeutic window. The therapeutic with efficacy percentage was 70%, higher than thousands of births observed in Latin America and other countries.
Director of the UCLA Comprehensive Stroke Center, and I'm going to be talking about the HERMI collaboration study of the relationship between onset to treatment time and outcome from thrombectomy for acute ischemic stroke. The objective of this study was to characterize the relationship between onset to treatment time for this breakthrough therapy of retrieval or aspiration of thrombus in acute ischemic stroke. We knew from the individual trials that there was benefit up to 6 hours of onset, but by pulling them together, we wanted to see if there was evidence of benefit longer. And we also wanted to characterize how quickly within the first hours after onset benefit declines with treatment time. We pulled the data from 5 randomized trials that included 1,287 patients on 4 continents. They were all acute ischemic stroke patients with large vessel occlusions who had been randomized to standard medical therapy, including TPA or not TPA if TPA was indicated, versus thrombectomy added to standard medical therapy on top of TPA if TPA was indicated. We found that time is critically important to the outcome from this treatment. Benefit was seen up to 7 1/3 hours after onset, but within those 7 hours, every moment counted. In fact, every 6 minutes that went by after hospital arrival, 1 fewer out of 100 patients was independent 3 months after their stroke if the artery had not been open. The limitations of this study are that they reflect what happens with large vessel occlusion patients, not medium vessel occlusion patients, and that the study was performed largely at advanced academic medical centers, and we'll have to see how well the benefits hold up in regular practice more widespread. The conclusions are that thrombectomy is an effective therapy, but it's time dependent, and treatment within the first 2 to 3 hours, having a short onset to puncture time, will dramatically improve outcome. These findings should drive system change for health systems and regional ambulance systems across the country and across the world. We need patients to get to the cath lab as fast as possible after they arrive. We found evidence that a good target might be a door-to-puncture time of 75 minutes for hospitals that do this procedure. And we need to reorganize our ambulance systems to get patients who are having more severe strokes due to large vessel occlusions to comprehensive stroke centers as fast as possible. This might involve routing select patients directly to comprehensive stroke centers to get this life-saving therapy early.
Conclusion. In conclusion, in the case of acute stroke, there is interesting certainly about the benefits and reach and administered intravenous Ateplase before endovascular thrombectomy. Endovascular alone was not inferior in determining the functional outcome, with a range of 20% confident regarding the intervention presented by intravenous Ateplase administered which 4 hours after the onset of symptoms.
Stroke is the 5th leading cause of death in the U.S. and the 2nd leading cause of death worldwide. Each year, more than 750,000 Americans experiences a stroke.
So it's critically important for patients to recognize the warning signs of stroke, get to the hospital as soon as possible, and for doctors, nurses, and health systems to then rapidly treat patients when they arrive.
Dr. Jeffrey Saver from UCLA and co-authors reviewed the outcomes of over 1,200 patients experiencing acute ischemic stroke in 5 large randomized clinical trials. Some patients received standard medical therapy, others received standard therapy plus treatment with a thrombectomy device. The authors found that the sooner the device, which pulls clots out of the affected artery and helps restore blood to the brain, is used, the better the patient's overall recovery. The study appears in JAMA, the Journal of the American Medical Association.
There was some benefit of therapy up to 7 1/3 hours after onset. That's an important new aspect. If you get the artery open at 3 hours, then 65% of patients will be able to live independently 3 months later. If it takes 8 hours to get it open, then only 45% will be able to live independently. It makes a major difference in outcome.
It is critical for the public to be aware of the signs of stroke. Dr. Saver says use the acronym FAST. If you see facial drooping, arm weakness, and speech difficulty, it's time to call 911.
Often the patient can't make the call themselves because the stroke's affecting their speaking or their ability to recognize they're having a stroke. So it's very important for family, friends, witnesses. If you see someone having stroke-like symptoms, call 911. Every minute matters.
Laura Berger, The JAMA Report.
Thanks for your attention. We'll see you next time.